Let's start.
All right. First of all, really a big thank you and gratefulness to Alan Yan, who has done an amazing job. Folks.
Appreciate. Welcome, everybody. Welcome, everybody.
We have had a fantastic time. Great hospitality and this was great, right? Yeah. So for this morning, Alan and we thought that we'll just do case discussions, right? Just case-based discussions and sort of bounce some ideas and learn from each other. And if we do not agree, we take 10 steps back.
There we go.
And then, right?
We have a shooting contest later.
Thank you. So we'll do our American style. If you don't agree,
Right. Resolve it in
resolve
the
it in the
Midwestern style.
Midwestern style. Okay. Yeah. Let's have some, good argument, good discussions. Obviously, it's a friendly way to learn from each other. And don't hold back. Don't hold back, folks. Just feel free to shout out. So, there are some of the cases which I just put together to kind of stimulate some discussion. There could be some better ways of doing things and some mistakes that can happen. So let me get going. This is beams versus RAS. We talked a little bit about that. So you see, if you have this kind of a scenario there, pretty bad deformity, chronic, I think icon holds 3 consolidated deformity. And this is some of the x-rays I get because, if you're on a WhatsApp group or some, people from India actually. So what's wrong here? Is this okay technique-wise? I know obviously we have put a beam and a plate. Huh?
Poorly done.
Sorry? Poorly done, yes. I mean, if somebody is as a great technician or a surgeon, they immediately know what's happening, right? So they know that the screw is missing the point, right? So, but again, so sometimes it's difficult to blame the technique. I mean, it's easy to blame the technique, but it could be the technician didn't do a job. And then you blame the technique sometimes. So you can see the screw is missing the TLS. That might still work though. I mean, that's the amazing thing about Charcot. They heal. No matter what you do, they heal. But, this is why, I have moved away from that because you see, it's a tremendous amount of deformity. You have to really correct it. And if you get it corrected, then you have a very high arch. So that's why, and then if you have a very high arch, then there are problems. So that's why I was just going to show you why I do what I do. You see, in my case, you see, if I try to put beam, first of all, I have to open up the joint, MTP joint, and then get it right. Or you have to really, abduct it and then elevate the first ray. So that's why, so, and even in the other, this is another case, I think. So you can see that even if you get the medial ray pretty good, and if you're putting a, can you see from there? Okay. And the fourth is completely missing, right?
Are you familiar with intramedullary and extramedullary beams?
So yeah, these
Concepts very well.
Yeah. So this is what you need to be talking about as to how it is to be done properly. These are the cases I get for a second opinion and this kind of stuff. So, but what we need to do is that everybody should be able to do it, not just one person from King's or one person from Italy. So you have to develop techniques which everybody can do it. Or, otherwise we'll get these kind of scenarios, right? So, or we have to be better at training folks. So those are the challenges we have. So again, you can see the screw occupies, but the tail is in the breeze. So does it matter? I mean, that's the question. So now here, this is why I do this. You may criticize me or you may think I'm doing something wrong. Feel free to shout it out. But, I feel that you have a better purchase if you engage the base. You have a plantar, thicker cortex. When you have a metatarsal, which is the strongest part of the metatarsal.
Sorry, Vinod. Sorry to interrupt you, but I think there's a very there's a very important thing that I think that as any fracture dislocation, you have to reduce first before you put your fixation.
Or take some of the bone away.
All these issues are because you have not reduced the dislocation, and if you're out of the bone, it's because you haven't done it, okay? And as any fracture dislocation, we have to look for anatomical reduction, and I think sometimes you can do that with bone resection and everything.
So what would you tell the surgeon to go all the way even more abduct the foot to get the fourth metatarsal
Probably, and
big inside?
this is why we have gone to gradual correction and distraction, because with the hinges and bone resection, it's very difficult to get an anatomical reduction. And the position of the beaming, it's telling you that. It's saying, hey, this is not reducted. You haven't corrected all deformities. And this is why we try not to do it in an acute fashion and try to reduce it.
And is it to correct the anatomic correction?
I think it's crucial. I think here the beaming is not good, and even the rafting, it's out of place because everything is
The question is, why can't you make your life easier? You know, why the hell you have to go through the head of...
Well, easier is not better always. But I think that
What
even though
easier
the rafting technique looks good, it's a lot of hardware instead that it can't be broken either way, just like the beams. But I think that either rafting or beaming, I think one thing that is, I think we should make like an agreement is that we have to reduce accordingly. And
You have to reduce it, but not over-reduce it. You don't have to be anatomic. That's why Venu said, you see...
But do you agree with me that the you getting out of place with the beams, it's because there's no enough correction, because your talus is not corrected with your first metatarsal, and that's where okay, you can do with the rafting, but
Talus is, in this picture, I don't know, what the surgeon was trying to do or what the reduction was, I don't know. Because again, these are not my x-rays, but I see this often. This is just an example to show the challenges people face. Yes. People face these challenges, okay? So you may be an excellent surgeon, you might be able to get the full reduction, and you can talk about how much reduction is necessary. Do we need to go full anatomic reduction? Should we need to, again, we talked about the arch. Do we need to really get that cavus?
It's alignment. You got this.
Let me see if I have a...
Basically, if a lot of midfoot...
See, this is the lateral for the same patient.
Yeah, it doesn't matter. So that,
right? And what's wrong with it? It's a Charcot guy. He doesn't have neuropathy. He has neuropathy, so,
So if I can emphasize about one point, yes, in the medial column, it is actually much easier to line up the medial column with the beam. We always start, because if you excise a lot of mid-tarsals, then the width of your forefoot distal segment doesn't match the width of your residual, the rear segment. There will always be overhanging. But we line up the medial column, beam wire, drill, beam, line up the medial column, but there will be overhanging. And the lateral column, extramedullary beam. This we've been doing for,
But would you have left the lateral column alone here? Or would you have done something?
But for this one, I would do lateral column as well.
So, how would you not miss it?
What miss it?
This guy.
No, it doesn't have to be intramedullary.
That's what I'm saying. You say that's why.
Yeah, but this has been we don't see, at least in the UK, we don't see very often this type of lateral column beamings for this type of presentation. There would have been extramedullary from the base of the fourth or fifth metatarsal, which is a very well-established concept for possibly 6 to 8 years. And that is what, but it is less common to see an extramedullary large beam inserted from the base of the first metatarsal, because it is much easier to line up first metatarsals to the
you're right.
to the
But
talus.
this case I got it. I don't know. You guys do best doctors.
When beaming started, though, when the superconstruct.
Superconstruct, yeah. But no, look at it. The date is.
Was that you were supposed to do it all, and so you did get these issues where you were missing on the.
Could have, but
Date is February. So anyway. But what I'm trying to say is, okay, so is this the end of the story? I will tell you why it's not the end of the story. And we have quite a few things to, but let's, keep rolling. So, and then this particular patient, this is way back, 2023, there was the overloading in the front. So they took that sesamoid bone away. Even though the arch is not too high, because of 4-foot loading, I think if you heard Dr. Kohler, Armin Kohler from Germany, he was mentioning that, They say that if you fuse the ankle or the foot, they have a lot more forefoot overloading, so it's no sesamoids, sesamoids gone. So because you're kind of doing something, you're trying to fix a problem, but you're trying to get, you're ending up with some other problem, right? So this is what's happening here. And then they did a cuboid section too. So, we can keep on doing that. I mean, it will keep on falling, and then you can see what's happening with the calcaneal pitch. It's going to go down and down. And so what are the solutions, folks, for this? So should we keep on shaving the bone? Or maybe, obviously, if you give them a total contact inserts and those expensive shoes, they might be okay. Let me keep going. So ultimately, we said, okay, we need to really, this is one of the solutions, okay? So we can actually get that calcaneal pitch up and do that. But that's one of the cases here. Any concluding points before I do one more, and then we can show some other cases. I don't want to hog this. So this is. So we'll do some forefoot cases. Okay, I'll show you this tale of two aggressive things. So I know people will do whatever works best in their hands, right? I mean, what do you guys think? I mean, you guys want to switch to beams, or have we convinced you to beams or anything else? I know you guys are an excellent fixer of frames. So you see, this is what's happening. We don't know. We don't have enough data to say, yes, everybody should do beams, everybody should do frames, everybody should do short screws. So I'm going to show, is it advancing there?
What we know is that compared to the old-fashioned fixation techniques, the beam principles and the fixation construct we achieve are better. But that is, that's one step, perhaps advancement, but we don't know where it will stop.
That's
it may
true,
not be
yeah.
worse.
And somebody else yesterday said, there's a spectrum of condition, right? I mean, not two patients are same.
Yeah,
Not two patients are
absolutely.
same. We see a vast, there are big people, small
Combinations
people.
and combinations.
Yes, and then there are people who have great sense, I mean, relatively well-preserved sensation, and then some patients who have no sensation up to the knee. We can do their surgery without anesthesia. Anesthesia still wants to get their money, so they will still do some medication and put them to sleep.
Anyone wants to?
Then yes. We'll have the video too, right? Video, Dr. House.
After video, make sure you use your microphone.
Okay, sorry. Okay. So I just want to, touch base, and I do have some forefoot cases as well, because we never discussed forefoot scenarios. But we'll, after this, I think we'll get whoever wants to go next. You want a forefoot? Okay. Yeah. So I'll quickly go over this, and if we limit our comments to brief, whatever is necessary, so that way we can cover a lot more ground. So you see, this is the kind of scenarios we face. I'm sure you guys also faced these scenarios. So sometimes you see, we see this, what I call as aggressive, a patient with aggressive loss of bone. Within few months, they will lose his bone. And you can see how this guy has lost his length. You can see the limb length discrepancy. And this is, this guy, I really wanted to do something about it, because I know somebody talked about you don't need to worry about the acute Charcot phase and this time. We can actually restore the limb. But his cardiologist scared him to death. He said, do not go to, get surgery done. So he believed him. You can see there's he's a sheriff, you see, he did well for some time. He kept on with this, there's his gait in the clinic there. You can, you see, nice big belly. And walking okay, right? I mean, they don't have a care in the world. The foot is breaking down, but he can walk with a smile on their face. And this is with the AFO time. He didn't want any crow walk or anything like that. That's all he would. He needed to be active. And months pass by. These patients sometimes don't turn up. You say, okay, come every few months. No, they won't. They will show whenever they want to show. And you can see how this ankle is going down and down and down. And now he's getting an ulcer. Now he says, do something, doc. So what do? I kind of wanted to get, I'm not as good as you guys are from, I just put a basic frame there. And I distracted it, hoping that I will get some bone there. And I'm going to show you this because, and he got fed up. These people do not like this frame. After they go 6 weeks, 4 weeks, 6 weeks, and they're after you every week, and they call the office, and you really, are forced your hand to get that. So this is what I did. I thought I will be able to secure this and stabilize this. I put him in a cast. We change the cast every week, and I'm going to switch to another case, which is a totally different scenario. Again, because I said there is a spectrum, from patients who throw a lot of bone, and some patients do not mount that osteoblastic response. So it's another case here. You see, you can see this guy is much worse right from get-go. Right from get-go is much worse. He got an ulcer there, and he's very unstable, highly unstable. Really, you cannot treat them in conservative manner. You can see how this calcaneus is lying on the side, and you can that's the so-called Harris view. So that was a long time ago. I think it was 2000 whatever year. So you see, this was just distraction. And this is what I was talking about yesterday. You see, these people, I used to use half pins a lot, and I know people are, talking about half pins versus smooth pins, and some people still use half pins and a combination of half pins and smooth pins. So you can see the midfoot has got a massive big hole there. You see, that's because they walk on this. And then I took the frame off, and then, what do? I stabilize with the hindfoot. Now, this is something which I found it useful. You see, to liver arm, there's a liver arm. So I pay attention in a sagittal view. The foot is not forwardly subluxed. Actually, it's gone back because it makes it more stable. And I found that works very well in my hands. You see, so it's a liver arm principle, and they tend to heal very well. Like you can see, massive big holes. They heal, and this is almost like a tumor. If you look at the distal end of the tibia, the bone is so much overgrown. It's like it's like a sunburst appearance. Like if you have a osteosarcoma patient, you can see that. You see, and this guy did very well. I've never seen him for, I was amazed with one similar scenario. You can get so much exuberant bone, and in other cases, you see, he failed. This guy, I'm going back to the previous case now. I hope it's not too confusing. That guy did not heal. He broke down everything. I was hoping that I will see some bone there, but no. And then he went on to go an amputation, so he didn't follow up, pretty unstable. So this is a tale of two stories. You see, so what is going on? Could I have done the TTT and saved him? I don't know. This was some time ago. And maybe I could have done a TTT and probably got him to have a lot more bone. So there are so many different things. And I will just go to the 4-foot cases, and then I will, any comments? So go ahead, please, while I...
I dare not comment as a dermatologist, but...
No, if you understand me, everybody understands.
With those ones with the ankle, there's ankle constructs that you can have. And is that right not to say? Because I try to say that because sometimes I push our surgeons as well to sort of do that. In just those two cases where you don't have much in the ankle, that there are ankle constructs that you can have to hold that a bit better. True or false? Just asking a question as to why not.
Your concept on osteoblasts, some reduced bone, is very interesting. But by and large, we aim to achieve good bone opposition. And for hindfoot nail, again, our study revealed that if you achieve good isthmus fit, long enough nail, such as that case example, then good bone opposition, we don't leave gaps, because Nina's and Prof. Edmonds' studies have shown that these Charcot affected bones do not produce, at least that we know of, adequate bone healing response. You don't see the kind of callus, the kind of normal callus we see.
Yeah.
So the best option is to reduce the gap. There will be shortening. Then, and that's, you should provide very robust fixation concept.
So I don't know, the second case, you see, we lengthened it, and he gave so much bone.
Interesting.
Like Elizarov thing, and then the first guy didn't. I don't know why. It's just totally, I just wanted to give
Good point.
different, spectrums to see, what we can do. And hopefully our friend here, Chris Manu, can figure out why they're not, maybe there's something systemic,
Even the hindfoot nail, the difference between bone healing response and non-bone healing response. Now, in 72% of patients, when we did not achieve isthmus fit, when we did not retain the medial malleolus, and when we did not include additional calcaneotibial screw.
Yeah, so yeah,
72%
you're right.
still
The heel, right?
achieve
So
bone
yeah.
fusion. But with these three together, 98% achieve.
Yeah, that's why
So-
I always add additional. That's a good point. This is, I'm sure people, just use the interlocking screws, but if you add additional screws, it provides additional stability. So they are, in my mind, they cry out for stability. So if you provide them the stability, they will form bone. But there are some, like ischemic Charcot patients.
Beyond our
That's where I think the TTT.
Non-modifiable factors, we can't do anything. The neuropathy is not going to improve.
So let me move on.
But at least under our control, the mechanical environment, if we provide as surgeons,
that's why.
best possible
Right.
mechanical environment.
So even though I put a nail, I actually do a cast change every week though, because they can, so swelling goes down. It's very, in my hands works better. But sometimes, we ask them to come, they don't come until 1 month, and then you have to. Let's move on. So let's
fixation, like internal, in those cases, like
internal and external. Yeah, you're right. You see, you're right. I could have done that. You're right. That's a good point, Gonzalez. So if I think back, if I had gone back on hindsight, I probably have done internal. I put a rod, then I put a frame, then he would have been much better controlled. That's a good point. Great point.
So we do
Let me move
internal
on.
and external stabilization, basically
Yeah.
internal fixation and external stabilization with a total contact.
But remember,
Instead, you can go for an external fixation.
remember, he hated external fixator. He hated every week. Every week, I go phone call and all that. So let's again, I want to keep the comments brief so that we can move on. Yeah. So this is what we used to do. Ross, the pioneer, where is Ross gone? Is she out hunting? There you hunting. Hats off to you. You started off the MIS revolution in Charcot. And honestly, this is where I started off as well. I felt happy, not happy, but, more confident in doing, I got the tactile feedback, sharpened my skills on Charcot patients. So, but this is what I used to do, you see, and this is what, 81-year-old female patient, my massive big ulcer down there. So we just sometimes just do a calculation. It healed, but it takes about 4 or 5 weeks to heal that, I don't do that anymore. So this guy, this is not, again, because I work in a big institution, there are so many other providers who are physicians or not, people do that. So this was dealt with somebody else at this time. He had this ulcer on, this is, again, make sure that you understand which side is raised. This is the right foot here. And, this is what was done for this particular patient. What would you do? I mean, you have this redness. If you have a cellulitis on the dorsum of the foot and you have an ulcer, that means, the bone is involved. And if you get an MRI, this is what we see. The whole bone lights up. The whole bone lights up. And very often, unfortunately, orthopedic surgeons, general surgeons, and many folks, they think, okay, the ray must go. The whole ray must go, because the radiologist will print out a nice little report saying osteomyelitis. The entire bone is osteomyelitis. So, and then, we see the lawyers before we see the patient sometimes. And this is what end up happening to this particular patient. This is one of the, and you do this bone, all these investigations, vascular investigations, ID guys, so on and so forth. So to cut the long story short, ended up with a first ray amputation. We see this scenario all the time. We see in the first ray, we see it in the fifth ray as well. But is that the end of the story? No, folks. They don't go away. They're the freaking player. They will come back, right? They will come back. The first, there's overloading here.
Could I just ask a question? In such cases, why would you do a 2-stage procedure? Because sometimes it says it looks osteomyelitic, but if you go in and then put antibiotic cement, sometimes in the marrow of the first, the hallux, and do a 2-stage, sometimes you can salvage the
Why didn't you speak to that surgeon then?
No, I'm just for us all. I'm here to
You're
learn.
right. No. Actually, this is.
If I have a surgeon.
If you wait for a second,
and remit.
If you wait for a second,
It's an interest concept because we're dealing with bone infections. We follow the principle of dealing with cancer. So like a bone cancer. So you were doing marginal or like total resection or even over margin. But nobody knows like for Charcot if it's non-osteomyelitis, what will be the principle to do?
Yeah.
And now we have those like intramedullary, like one stage for a little cerumen.
One stage cerumen G. Yeah.
Anecdotal is they're doing well.
You're right.
Now, the other thing is, I do not agree with one thing. So the first rate resection is probably unnecessary. I had a very good successful rate with fifth rate resection because my purpose is trying to narrow the foot. Shorten the foot and narrow the foot. And I have problems because the Charcot foot, the anatomy reduction is almost impossible. Because what happened to Charcot, they are like a volcano. After volcano, everything changes. So you are not able to get into an anatomical correction, especially their foot is shifted. When they push it there, I have a hard time closing the wound. So I take the fifth ray out. They narrow the wound, and they never had any issues.
But do we leave the attachment at the base of the fifth metatarsal?
So I learned from Vinod, it's like a transfer of those tendons is actually not as difficult as you thought. They'll transfer those tendons just like you do in fifth rate resection. You transfer that lateral, perineals into the cuboid. And that actually they're doing well.
That is why, you see, if you don't do the tendon balancing, most people don't. They will just take the fifth ray out, and then months later, what happens? You get a rigid inversion deformity, and then your next thing you have is, I have an example like that too. I have so many examples.
Just exercise the necrotic bone.
So
all that bone edema, marrow edema, you don't need to physically remove it. Drill, probe, and inject.
I want to quickly come to what Chris Manu. He will be very happy that we took his advice. But this was all before. You see, I'm trying to. I'm happy to. I'm able to get those records because all this was done in my hospital. There are hundreds of providers in my hospital. So,
Question for Dr. Miller. Ross, have you done like a dorsal minimally invasive?
Can I just proceed that, and you will get the answer from Dr. Miller from me. Okay. So So you see, the 2 years later, after 2 years, you see, this is what has happened. Okay, this is what happened, and like I said, it doesn't stop. You see, that if you just do one solve problem, they will come back with another problem. Then it comes with a cuboid. So this is where I sharpen my skills. I just go with a little MIS thing, and I think there is a little, I happily do this, even though there's also no problem. This again, rules do not matter. The regular rules we follow in non-neuropathic patients are different in neuropathic patients. So, even if it's an infected ulcer, you can just do this and get away with it, So again, I'm going to rapidly go through this, I sometimes inject some antibiotic cement mixed with it just to and they heal. Yesterday somebody was talking about this ulcer healing and all this variety of products. You put this thing, you put that thing, PDGF, nonsense. You just remove the bone and the ulcer will heal within a few days. So you see this guy gone. Now end of story? No. The story continues. This is the right side. So pay attention with the side. Okay, the right side was done a long time ago. He came back with an ulcer in the midfoot. We took care of him, so he's happy now. But they don't, obviously they will say, okay, get proper shoes, diabetic care. No, nobody follows. Nobody listens to you. They come in, now he comes back. He didn't go to the previous surgeon. He said, no, you fixed my problem here. I'm going to come to you. So this is where I took advice. I called UK King's College, and I said, can I speak to Dr. Manu? What should I do? And he says, why don't you do a single stage? Why don't you do a two-stage surgery? He said, and this is what I did. And I spoke to Dr. Miller at that time. No, I did not. I know I'm just making it up. But this is what I did. I just used MIS dorsally, and I put this bone cement, antibiotic cement. Did I follow your advice, sir?
Cement or cement?
No, like injectable. I don't want to create, some antibiotic mixed with absorbable.
One of the comments I want to make, and a plea to you surgeons as well, is that we sometimes say there's nothing minor about minor amputation. And I think we also look at the mortality. There's also, I think anything that you can do to try and save it, prevent the amputation, I think it is worth it.
Man, why didn't you become an orthopedic surgeon? Why?
I mean,
Why?
Yeah.
He's right, actually. Toes don't get that reputation they need. They are very quick to remove the toes. But the toes, if you look at the tendons going to the distal phalanx of the toe, if we dissect that the width of the tendon is so big, so big. Why has God given us this strong tendons? The toes actually help you get your balance, help you with the push-off. I'm not quick to give up on the toes. You see, that's why I like to preserve that muscle strength. Thank you. You're a wise man. So this is what we did for this patient. Honestly, the ulcer will heal. Ross, thank you for introducing MIS for us. You see, and this is another story. See, this is commonly done. This is a hallux valgus. I know there are many ways to deal with this too. Some people will just cut the FHL. Some people will just remove the head of the metatarsal. There are so many different ways to deal with this, you see. So again, I'm not quick to get MRIs and things like that on this kind of scenario. But if you do, this is the story before on one side. So I have cases which have been dealt by somebody else on one side, and then, sometimes they figure out there's somebody else who does these things. And, so you can see, again, the questionable, he says questionable early osteomyelitis. That's a good radiologist right there. He didn't say definite osteomyelitis, but that's enough for some people. They go ahead and...
friend, right?
So what?
He's not being friendly with you there.
He's the radiologist. But I was not involved at this stage, okay? But I'm just telling you because I have access to the records, because in a big university hospital, I can dig in and then be a detective, say what the hell did they do, where did it do, and all these things. So they did put cement, but that's never the end of the story. But, he did heal. But like you said, I would not have done that. I would have preserved the length, the toe and the function, because it is important to see. Because now what happens is we'll get ulcer in the second ray and third ray, and, then they subsequently, it's like what we call as nibbling disease, and they go up to the BK. We've seen this story play out so many times. So, but then that's a revision. They did a revision of a revision. But this is, again, I'm not involved here. So now I'm involved here right now. So it comes back to this at this stage. There's a right side and left side. So I'm dealing with the right side now, So I said, well, I'll just do this. There may be different ways, but this is way which I thought, why not do this? I did bunion surgery. I shouldn't have done it, right? You do it? Oh, thank you. But you don't know the story, though. You have a crystal ball? Who thinks this will heal well, and who thinks this does not heal well? Who is going to go tank down? What do you think? All right. Okay. So anyway, but you're right. Actually, again, I called Ross Miller in Scotland. She was in Fiji at that time. She told me, just do this; it'll do work. Okay. And she did. He did actually very well. He did actually very well. I was surprised. I knew I just kind of changed the alignment. Really, I'm trying to shift the alignment. That's what I did, mechanical, yeah. So, I could have just, some people just say, take the head off. But then you're making the first ray dysfunctional. It will not carry the weight, right? That may be a way to get rid of the ulcer, but is that the best way? We could debate about that, or we could see a better answer if we can get. But the ulcer completely healed, and he was so happy. And look at this very designer footwear. They can't afford. They really can't afford, because they are these people. Now Medicare obviously pays. We pay, right? Our taxes. We pay for the 3 inserts and 1 shoe every year. But these people who were in 30s and 40s, not yet on Medicare, they can't afford their $400 inserts 3 times a year and so on and so forth. You see, he'll be out of his so on and so forth. So. Anyway, this is the one I think we did on the just one case, and then this is again a 4-foot ulcer. So this is where you see, why do you think the ulcer came on this particular scenario? Why do you think there's ulcer there?
Dorsal.
Is it so? When I ask this question, some people say footwear. but it is a muscle action. See, it's a dorsal bunion, it's a strong pulling. So unless, and this patient went for IV antibiotics, MRI, you name it, for months. This patient was dealing with this problem, and then wheelchair also most of the time. And what do you do for this? You see, so this is it's 2016, miserable, and then I said to give more antibiotics. What do you do? Do you do MRI scan? And what will you learn from that? Do total bone cancers? And some people might say, okay, what about vascular studies? Yes or no? We can talk about that at length or ad nauseum. Excise the head. And some people would get the ulcer healed, I think, with that too. But what about reduction and fusion? Internal fixation or external fixation or both? So this is, because of time, I'm just going to go rapidly what I did. So, again, my strategy was to decompress the ulcer, you see. So wherever the bone is actually pushing, whether it's a muscular force, whether it is a plantar weight-bearing force, we need to get rid of the bone. The bone is the culprit here. No amount of whatever skin graft substitute you put in and so on and so forth will not work unless you solve the underlying problem. So this is what we did. At that time, I did not call you. I did not know the MIS stuff can work there. It's a MAS surgery, maximum invasive surgery. But I was able to reduce it, and this is where I started rafting concepts. So then I thought, okay, maybe man, why not keep up with it? So, but I just put this an external fixator, stabilized the big toe too. At that time, I was using half pins. Yeah, and this is what I want to know what Dr. Kirienko thinks about is the bottommost ring is not attached to the foot ring. The threaded rods go all the way to the tibial ring. So it's like a total, like the Sarmiento external fixator. So the foot is not experiencing any weight. So if you look at that, there are no nuts on either side, nuts on the other side of the foot ring. So you see, even if the patient walks on it, you see the bottom ring bypasses. So we published this technique called as a foot cradle technique in foot and ankle some time ago. And because again, there is no nuts on either side of the foot ring. So basically the force is transmitted from the bottommost ring to the tibial ring. It is like a Sarmiento external fixator, if you will. So it offloads the foot. I had trouble getting this published because the engineers did not understand the concept. Or the reviewers did not. So, but I've used this quite a bit, and none of my foot things broke, but they did have over. So this is just a few months later. Oh my God, and they heal rapidly. Once you take that thing away, they heal rapidly. And this is one of the most grateful patients I had. And she was delighted that she was able to walk. Delighted, honestly.
Across the TMJ, only the navicular.
Oh, sorry. What was the question?
So
Only the zone of damage. Only the unstable area. Only the unstable area.
the tail of it as well.
Yeah. So I could have gone a little bit deeper into talar head. I don't know why. I didn't do it, but I thought that because I'm putting a frame as well on it, so it's like a super construct, if you will. And Dr. Kirienko says, should leave the joints alone. Some of this. And so, so then you see, this is another question I have in my mind. So now, if you look at the talus, because I did not prepare or fuse the talonavicular joint, should I go proactively and remove those screws so that don't have that metal in the bone kind of causing this? I don't know those answers, you see. So they are tickling the talus, So okay, shall I let them tickle? I don't know, but I will stop and then thank you very much. For that.
Yes, let's do it. Okay, so I try to prevent disasters later when we're shooting. So I try to rig us out. So I think Dr. Vinod's rafting technique is very similar to the extramedullary beaming. So the benefits of that is it's much easier to shooting into the bone mass. That's where we want to go to. So I have a hard time beaming third and fourth. They will poking out of because the midfoot and forefoot are not aligned. And hindfoot. The one that I find is useful for me is I put a screw from the posterior calcaneus to the cuboid, the straight shot. And that one is like an A-frame, kind of one of the most important for me. So I got subtalar beaming, I got a posterior to the cuboid, and then I got my first ray lineup I learned from you, and that works out pretty well for my patient. I do have a question later on if we have time. I always have a hard time in the lateral column. So that reduction of the cuboid is such a headache for me. And once I tried a couple of times, I lost a lot of stability in lateral column. And I using extra beaming. Actually, I hold it on pretty good, and they work to my surprise. But anyway, I tried to reconsult you guys. I think an extra beaming is good.
Prepare those joints, for example.
I do. I prepare all the joints that I want to shish kebab them. You know, and I think all of those problems that we see, the biomechanical correction is the key to my mind. So if you're not corrected, you're always coming back with a problem. Either you correct the bony procedures or you correct with soft tissue balance. Those patients have a challenge to find a good soft tissue to do, though. But, you know, so.
So basically, that particular.
Yes. Can we pass that?
Let me see if this goes.
In that particular case example earlier, a beautiful reduction and excellent fixation using grafting technique. Now, the most recent X-ray has shown that the TNJ, in fact, the rafting screws have loosened a bit, and the TNJ, compared to the last slide shows the pre-op X-ray, the TNJ was completely normal, and the most recent X-ray, which shows a lot of osteolysis around the TNJ in an irregular way. Now, if we go back, take the clock back to the patient's kind of situation before he developed Charcot's. Had neuropathy, peripheral neuropathy, and some minor trauma that resulted in that midfoot Charcot, and that was managed with beautiful surgical correction and grafting fixation. But the TNJ was not prepared, so TNJ would not fuse. Now, the current situation is that neuropathy is still there.
There you go.
It may have even deteriorated slightly because it's a progressive condition. That joint, which was completely normal with normal ligaments, normal mechanics, now with the continued those risk factors, and it is an abnormal. So what are the chances of that joint functioning normally or not developing problems in future? So at least under my control as a surgeon, I would like to avoid such predictable problems in future. So as you know, we prepare the joints and then make sure that the screw threads go across to achieve the compression, nice bone opposition, and stronger construct.
One tip that I learned, mistake, I wanted everybody to learn from a mistake so not make the same mistake. Those guys' bone is different.
Yes.
So when I prep the joint, so you cannot prep, so we know the talus is the hardest bone. The problem of the Charcot patient, don't take that in your mind. Their talus is different. I cracked the talus a couple of times because I didn't expect the Charcot changes. And then I have a hard time to put everything together. So this is like a learn from mistake, so.
So this is what baffles me, see, so there's so many ways to skin a cat, they say. I don't know why they say skin a cat. Does anything skin a cat? I don't know, anyway. But we are able to go to a successful endpoint. Whether you do a beam, whether you do a RAST, whether you do a X-ray, we are reaching that endpoint. So,
They're everywhere it goes to the room.
our own thing we do, we become expert in it, and then we get success. Ultimately, what do we want? We want success.
Yeah. Now, I have a question for both of you, for you and Vinod. So correct me if I'm not right. So I think the reason you need a beam to go through a normal bone to normal bone, bypass the backbone. I think that's the reason.
That is the big
So that is what beam is. You have to hook on the good portion of those two ends and bypass whatever you think is going to have a problem. So I always worry about it. Or a short fixation may not do the trick. So is that
Rafting as well.
Yeah.
What you're doing with the beam, I'm doing exactly, because you see, I'm
Yeah.
using the base of the metatarsal.
Yeah.
If you if you look at the head, the screw in the head,
Yeah.
the screw in the head of the first metatarsal, it can toggle,
Right.
But if you are putting the head of the screw
Yeah.
from the plantar medial thickest part of the first metatarsal,
Yeah.
you have a better first fit.
So yeah, you sort of follow the same principle.
My hands are working.
Yeah. So now, before all those beaming things, there's more, common way we're doing it is plantar plate. Lucian, that's what he does. Plantar, that biomechanically makes sense. We put it in tension side, we put it in compression side. We all know that as an orthopedic surgeon. So that one works, and I always add a beaming and add it to that in a plantar medially, add a plate and going anywhere to the big bone mass, and that works out good for me.
Beam principle, the alpha is exactly the same.
Yeah.
You're right.
Yeah.
It depends on if you leave the lateral cortex of cuboid intact,
Right.
then your beam will provide this fixation concept.
Yeah. And one thing is, Samarco, I will get him here next year. So Samarco, it's the junior Samarco. The senior Samarco has already retired. Junior Samarco, I will get him here, and next year we will have a beaming lab in our conferences.
Or just things.
Yeah.
Anyway, but
So we have a presentation of the
Alan, I did not realize I may be doing a plantar plating. Just a little bit about that. I may be doing that. That's a good point.
So, we ready?
We're ready, yeah. Finally, sorry.